Welcome to the Radiology Advances podcast. We're your source for really digging into the research that's shaping your future in radiology.
Yeah, we try to bring you the stuff that matters.
Exactly. And today we're doing a deep dive into a study that honestly could really change things up in interventional radiology. We're looking at this paper, Comparison of Robotic versus Manual Needle Insertion for CT-Guided Intervention, Prospective Randomized Trial. It's by Takao Haraki, Yusuke Matsui, Tetsushi Kamigawa, and colleagues over at Okayama University, published in Radiology Advances. A really interesting piece of work. So our mission today is pretty clear. Figure out what this actually means for you, for your practice, and, where procedures are headed.
It's not just about the data points, right? It's the bigger picture.
Definitely. So let's start with the background. What was the problem they were even trying to solve here?
Well, it's this fundamental tension, really, that's been around for a while in CT-guided procedures. You've got CT fluoroscopy, which is fantastic for precision given real-time imaging.
Right. Faster, more control for the physician.
Exactly. Big improvements. But the downside has always been radiation exposure. The person doing the procedure, the physician, is right there, absorbing radiation. It's been this trade-off, this sort of necessary evil to get that real-time view.
And people have measured this, right? It's not just a theoretical risk.
Oh, absolutely. The paper cites earlier work, studies by folks who actually documented the radiation doses physicians were receiving. So it's a known, quantifiable issue. Finding a way around that exposure without losing the benefits of CT fluoro, that's been the goal.
Okay, so that sets the stage perfectly. What was the specific question Haraki's team wanted to answer with this study?
Their core question was pretty direct. Can a robot insert a needle for a CT-guided biopsy just as accurately, or maybe even better than a human operator?
A straight head-to-head comparison.
Precisely. Robotic versus manual, focusing primarily on needle insertion accuracy. They set the study up as a prospective randomized open-label blinded endpoint trial. They enrolled 22 patients needing CT fluoroscopy-guided biopsies using an experimental robotic system called ZeroBot that is not commercially available.
Got it. So how did they measure accuracy? What was the actual metric?
Good question, because it's central to the results. The primary endpoint was accuracy, defined as the 3D Euclidean distance, basically the straight line distance in 3 dimensions between where they aimed, the target point, and where the needle tip actually ended up after insertion.
Okay, so lower number is better. Closer to 0 means more accurate.
Exactly. 0 would be a perfect hit. They also tracked other things, secondary endpoints, like technical success. Did they get the sample? Pathological findings. Was the sample adequate for diagnosis? Patient radiation dose using dose-length product. And crucially, the physician's radiation dose, the effective dose, usually in microsieverts. Also, how long the CT fluoroscopy was on and how long the needle insertion itself took.
And they had a specific target for accuracy, didn't they?
Yes, that's key. They aimed to prove the robot was non-inferior to the manual method. Statistically, this meant the upper limit of the 95% confidence interval for the accuracy difference had to be less than 3.0 millimeters.
Okay, so if the robot was statistically shown to be no more than 3 millimeters less accurate, it met the goal.
Essentially, yes. That 3 millimeter margin is a clinical judgment call, saying within this range, it's considered acceptably accurate.
All right, this is where it gets really interesting. Let's talk results. What did this comparison actually find? Did the robot measure up?
It absolutely did. On accuracy, the main goal, the robot was officially non-inferior, but actually the numbers looked even better than just non-inferior.
Oh, how so?
The mean accuracy for the robotic group was 4.8 millimeters compared to 7.0 millimeters for the manual group. So on average, the robot was more accurate and closer to the target.
And the difference was statistically significant.
Yes. p less than 0.001, the mean difference was minus 2.1 millimeters, and at 95% confidence interval, minus 4.7 to 0.4 millimeters was well within that 3.0 millimeter non-inferiority margin they set.
Wow. So mission accomplished on accuracy. What about the other big one? Physician radiation dose.
The effective dose to the physician in the robotic group was 0. Compare this to the manual group, where the median dose was 1.0 microsieverts. It basically eliminates the operator's radiation risk during insertion.
That is genuinely game-changing. What about the patients? Did they get more radiation with the robot?
Nope, no significant difference in patient dose, DLP, between the two groups. So the benefits for the physician didn't come at the cost of higher radiation for the patient.
Okay, what about technical success actually getting the sample?
100% technical success in both groups and 100% success in getting adequate pathological findings too. So from a clinical outcome perspective, both methods worked perfectly in this trial.
Any difference in adverse events, complications?
No major adverse events reported in either group, and the rates of minor events like small pneumothorax were similar.
So better accuracy on average, 0 physician radiation, same patient dose, same clinical success. It sounds almost too good. Was there any downside?
Well, there was one interesting finding that might seem like a downside at first glance. The CT fluoroscopy time, the time the scanner was actively imaging during the procedure, was actually longer in the robotic group.
Longer? That seems a bit counterintuitive if the robot's supposed to be precise. Why would it take longer?
Yeah, it's a fair question. The authors offered a couple of explanations. One is simply the learning curve. It's a new experimental robot, so the operators were likely being more cautious, taking more time getting familiar with it.
Makes sense. What was the other reason?
This was maybe more interesting psychologically. Because the physician wasn't getting irradiated, the pressure to minimize scan time for their own safety was removed.
Ah, right. In a manual procedure, you're always conscious of the dose you're accumulating.
Exactly. You might take a bit more time to double-check, confirm positioning, make absolutely sure, precisely because you can without adding to your personal radiation burden.
That's a fascinating insight into how safety features can change behavior. What about the accuracy details? If the robot was sometimes off, why was that?
The authors suggested that the small deviations they did see might not have been the robot making a mistake per se. It could have been down to human perception error, the physician identifying the exact target point on the CT images to input into the robot. It points to the importance of that human-machine interface.
So it's not just the robot's mechanics, but how the human guides it. How does the Z-Robot compare to other robotic systems people might have heard about?
Good point. They're different types. Some are more like sophisticated needle guides where the physician still manually pushes the needle. Others are fully robotic, but might work differently. The Z-Robot's potential advantages seem to be its pre-insertion targeting accuracy, and then maintaining really good needle stability during the insertion itself.
This all sounds incredibly promising, but, every study has limitations. What should we keep in mind when looking at these results?
First off, it's a small study. Only 22 patients and done at a single center. We definitely need larger multi-center trials to confirm this.
Okay, sample size, what else?
Blinding was an issue. Obviously, the physicians knew if they were using the robot or doing it manually. You can't really blind that kind of intervention. Also, different physicians performed procedures in each group, which could introduce some variability based on individual skill or experience.
And the learning curve you mentioned.
Yeah, that's a limitation too. The performance might have been even better if the operators were fully experienced with the Z-Robot from the start. They also didn't stratify it by things like lesion size or location, which can affect difficulty.
Right. A tiny lung lesion is different from a large liver mass.
Exactly. And CT fluoroscopy use wasn't perfectly standardized. Plus, remember, the study design aimed for non-inferiority. It wasn't designed to prove the robot was superior, even though some results pointed that way. Future studies might aim for that higher bar.
That's a great overview of the caveats. So let's try and wrap this up. What's the big takeaway message for someone listening to this?
I think the core message is that robotic assistance for these procedures is looking really viable. This study provides strong evidence that you can achieve, at least comparable, maybe even better accuracy compared to manual insertion.
while completely eliminating radiation exposure for the physician doing the work.
That's the kicker. 0 dose. That combination of accuracy and safety is incredibly powerful.
And thinking bigger picture, what are the implications for interventional radiology moving forward?
Well, if systems like this become more widespread and refined, you could see a few things. It might make complex procedures more accessible, potentially lowering the barrier for physicians earlier in their training, because the robot provides that stable, precise platform.
Democratizing complex skills in a way.
You could put it that way, yeah. It might lead to more consistency, potentially improving safety and outcomes across the board.
Definitely something to think about. Thanks to Takao Hiraki, Yusuke Matsui, Tetsushi Kamagawa, and colleagues for their fascinating study on the use of robotic needle insertion for CT-guided interventions. If you found this episode informative, please rate, review, and subscribe. It helps more people discover the podcast and supports the broader conversation around innovation in imaging. You can read the full article and explore more great content at Radiology Advances on the journal website. This episode was generated with the help of AI, but all content was reviewed and verified by its editor, Dr. Nelson Gill, for accuracy. Thanks for joining us. See you next time.